This week on the BackTable podcast.
Staying in our lanes of ICIR and vascular is just very unhealthy and very unproductive for serving our communities, for serving our patients, and frankly, for serving our profession. And so the better ways that we can align is really critical. And so I think, the crux of this is it's the turf battles and the business wars, right? We all want to have our areas and, we all want to, maintain our practice and it comes down to economics. And I think that's where when you can find a model where we're all on the same team and we all benefit, then you can say, oh yeah, what's right for our patients, our community is right for us economically as well, is right for us in our skill set, in our skill level.
Hello, everyone, and welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. First, a brief message from our sponsor.
One of the biggest challenges clinicians face is not related to devices or techniques, it's the workflow. For conditions like aortic emergency, PE, and stroke, outcomes are impacted because it takes too long for treatment decisions to be made and for patients to receive therapy. Viz.ai leverages artificial intelligence to coordinate care and improve workflow and is trusted in over 1,000 hospitals across the U.S. and in Europe. The platform uses AI to detect disease, provide access to high-fidelity imaging and patient information, and allows you to communicate securely through the HIPAA-compliant communication tool conveniently on your phone, desktop, or within the radiology workstation. No more asking the ED to send you a grainy picture or making countless phone calls to activate your teams. Visit Viz.ai to learn more. Boston Scientific can help you advance, connect, and equip your practice with Nextlab. Nextlab is a suite of solutions and partnerships tailored to meet the needs of your OBL or cardiovascular ASC. Nextlab goes beyond Boston Scientific's medical devices to provide ways to reduce expenses and increase efficiencies in your business so you can focus on patient care. Whether you have an established lab or you're thinking about opening one, Boston Scientific can help. Visit bostonscientific.com/Nextlab. And now back to the show.
Today, we have a very special episode discussing the collaborative vascular surgery IR practice. We've previously discussed practice styles and structures on prior episodes, including, the pros and cons of the traditional IR-DR practice, the strictly OBL or OBO-ASC practice. And we've even had on prior episodes 129 and 205 with Jim Melton and Blake Parsons, talking about these combination vascular surgery and IR practices. While they're still rare out there, I do like to examine them and see why they're successful, how they've been successful. And so today I'm really lucky to be joined by interventional radiologist Neal Khurana and vascular surgeon Chad Laurich, about their partnership in practice, how they met, how it works, and their vision of a more collaborative approach to the endovascular specialties. Welcome, guys.
Thanks, Aaron. Nice to be here. Yeah.
Thanks for having us.
Yeah. So before we get started, I just want to do a quick intro, and we'll start with you, Chad, kind of where you're trained, how long you've been in practice, and where you're at today.
Yeah. So I'm originally from Minneapolis and went to medical school there. Ended up going to University of Iowa for general surgery and vascular. I did the 5-2 program with the 2-year vascular fellowship. I didn't know about vascular before I went to Iowa and just fell in love with it there. And those guys were fantastic. Still have tons of gratitude to my mentors from Iowa. And so that's where I did most of my vascular training. Thought I'd stay in academics. I was an upper Midwest guy, Big Ten guy. I thought I'd stay in academics and started kicking around that. And then through contacts with reps and some others, I got connected with a practice in Sioux Falls, South Dakota, which I thought I'd never live in the Dakotas, but it turned out to be fantastic. The level of care they were doing was phenomenal, and ended up switching my plans and going into practice there. And that led to us coming out into our own practice here about 4 years ago now this summer. And that's how we kind of got to our current practice.
Great. Thanks for that. Neal, tell us about your journey to where you are today.
Sure. So I'm a Chicago guy and trained there at Rush University. Learned on my PVD from Buehlin Arslan and Cenk Turba, and practiced there for 3 years. And I think we'll get into the story of how me and Chad met, but joined Chad 3 years ago here in Dakota Dunes, South Dakota.
So, Chad, how many people are in your practice? When you started it sounds like Neal joined a little bit later, but when you started it, was it just you solo, or were you with another vascular surgeon?
Yeah, it was just me solo. So I'm about an hour south geographically from where I practiced for 7 solid years and had a real large practice there. We knew of the need, and actually I went nationwide and was thinking about stepping out of the hospital employed model to have my own practice with an outpatient center, and traveled the country, went around to a lot of different sites, did a lot of research on different markets, and turned out there's a phenomenal market, phenomenal need just an hour south of us. So that's how I ended up coming down here. So I had a bit of a reputation and whatnot in the region, which helped. And then just kind of did some research on the market, found some friends. There was a phenomenal general surgery group in town that was super helpful, and ended up kind of dovetailing with them on clinic and then opening our outpatient center, and really got connected with the hospitals in town. And that's how I got started. That lasted for not even a year, just a few months. And I'm like, okay, we're going to need some help here. So we can get into that story too, of how Neal and I came together and where our practice is at now. Now, the market, I think, needs 2 interventional radiologists and 2 vascular surgeons. I think if we have 4 strong guys, that's going to really serve our market well. And that's really what it comes down to. We can talk about that a little bit more too, and kind of what motivates us and how we think about our practice. But it's really about the need. It's about our outcomes. It's about the community. And but I think that's where our practice is at, and where we're going to fly.
So I don't know if I caught it. So is it just the 2 of you, or do you have another vascular surgery colleague in the group as well?
So currently we've got Neal and one. Currently it's Neal and myself. We are actively looking for an interventional radiologist and actively looking for another vascular surgeon. So we didn't talk about plugs or anything like that. But
plug away. Yeah.
As we get into it, I think we're at that point in our practice where we've kind of had the philosophy of we're both a little, we both love to work and engage in our work, but we really are looking for the right fit, the right guy who's going to fit with their ethos, as far as our ethos is put the patient first and do what's right for the patient in every situation. And then also professionally, we've got a very much a gratitude, collaborative type of mentality. And that kind of spirit of practice and professionalism among us, I think, which we'll get into throughout the hours, is really important. So we're looking for additional IR and additional vascular surgeon like that.
Neal, let's jump into the story about how you guys met.
Yeah, so I was in Chicago. Like I said, I was with VIR Chicago, excellent group out there, and they kind of laid the groundwork for where I wanted to head professionally. They had a very clinical practice model with 3 clinics covering 6 hospitals. There were nine IRs and 6 advanced practice providers. So coming from training and getting into a practice like that really opened my eyes on what IR should be. We all talk about the clinical model of IR, and as much as we all talk about it, to see it in real life was quite inspiring, actually. So I was at dinner with industry, basically just chatting about business and stuff, and my rep for this company said, "Hey, you know what? There's a vascular surgeon out in Sioux City, Iowa / Dakota Dunes, South Dakota, who's looking to team up with an IR." And I said, "Oh, that's interesting." And I said, "Oh, I should put you guys in touch." And I said, I wasn't really looking. And so I just kind of kept it in my back pocket and didn't think about it. And a couple of weeks later, I said I'll do due diligence and give Chad a phone call. It's always interesting to hear what people are developing and just to learn for what people are looking for and where the market's headed. And what I thought would be a 10-minute phone call ended up being like an hour and a half phone date. So we broed it out for like a good hour and a half, talking about pedal access and CLI, and it was really just refreshing to talk to a vascular surgeon. Now, mind you, I'm only 3 years out of training, so I wasn't tainted yet as far as the sandbox, playing in the same sandbox and the whole turf wars. But it was just really refreshing just talking to somebody who immediately saw me as a colleague, saw me as a clinical equal. Spoke to me with respecting my field, basically beyond PVD. Just saying, I think, Chad, you can mention about how you had a little IR exposure in your training as well, and probably set the stage for our collaboration. But so after that phone call, it was basically I had to come see what he was doing out here. And what really piqued my interest as well is obviously the office-based lab and how we developed that and really what it looked like. And I came out here, and it was pretty much a done deal after I saw the potential, the lack of IR in the area. There's probably not another IR who's doing, oncology within 80 miles from here. I mean, Omaha and Sioux Falls are kind of where the next place to go is. And so, you see this massive community without proper IR. And so I knew I would be busy. I knew I could be autonomous. I knew I would have support from Chad. He also has incredible, business acumen as well. And so I know he wouldn't steer us wrong as far as, financials and how to kind of be successful from that end. It was all in all just like I was like, this is a diamond in the rough. Nowadays, private practice around the U.S., it's all getting eaten up by conglomerates and larger healthcare models. And so I thought, my dad's a physician and he was private practice. And I said, this is what I want to do. This was my calling. So
yeah,
that's about it.
So Chad, from your viewpoint, what with this conversation with Neal, what did you see as the opportunity here? I mean, this is very progressive, right? This is very kind of open-minded of you to think about bringing a different specialist as part of your group. So tell us what your mindset was.
Yeah, absolutely. So when I was at University of Iowa, there was a really unique guy there, Mel Sheriff-Fuden, who's still practicing and just an awesome human being. He was actually the head of interventional radiology for a period of time as a young guy, as a young IR, really talented. He came back and did a full general surgery vascular track. And he was a couple years ahead of me in training when I was a resident. So when I became a fellow, he was like a second year, going to third year staff. And so it was awesome to have fully IR trained, fully vascular surgery trained staff. Now, mind you, I had phenomenal other guys with John Sharp and Jamal Bala and Tim Kruswick and Rachel Nicholson, just phenomenal people who were really provided a great breadth of vascular surgery. But there was this unique perspective with interventional radiology when I was training at those key years. And we were welcome in IR as vascular fellows and vice versa. There's a IR attending who was doing carotid stenting at the time. She would just do special sessions with us and was really generous. So there was that nice collaboration that I experienced the benefit of as a young pup, so to speak. And so that never left me. When I was in Sioux City and Dakota Dunes then and opening the practice just a few months in, like I said, it was very clear that I needed some help because the volume of work was going to be really high. And there is a huge need for interventional radiology in our town. So when I came down and opened practice, honestly, I didn't have in my mind that I was going to, that wasn't part of the original game plan and format is to have a combined group. But it became very clear about 6 months in, maybe not even that far, that there's a massive need in our town and the breadth of skill that high-level interventional radiologists would add to our town would complement and go far beyond what I'd be able to do or what another vascular surgeon would be able to do. So when I was, I started putting the feelers out there and started really thinking about it. And then things aren't random, so when you really start to go down these roads and you think, oh man, this would be phenomenal. A conversation leads to another, leads to a conversation with a rep with Neal out in Chicago, leads to us being on the phone. And then a few minutes in, it's like, well, did I just meet my new best friend?
Yeah.
Kind of like stepbrothers. And we're like, okay. So we saw very, very, very much eye to eye. And there was just a mutual respect, a mutual sameness about our mission. And I think in how we saw our practices and saw life. So all those things helped a lot to get us established. And now where we're at right now, it's a lot of it's come to fruition and it's really satisfying. I mean, honestly, the level of care and drive and just passion that Neal brings to the community is, it's phenomenal. Like what has been done in this community for this underserved community now and the skill that he does and brings and the difference he's made is just it's really humbling to see, for me to see. And it really inspires me to do better on my side of the practice too.
So Chad, you mentioned that you had met Jim Melton before, and we talked about how Jim and Blake have a similar collaborative practice down in Oklahoma. Was that before you'd consider bringing on Neal, that you had met Jim?
It was. So when I traveled around, before I opened the practice, I traveled around. One of those places was in Oklahoma City, in Jim Melton's lab. And so I kind of saw the model he was doing in combination with interventional cardiology with Dr. Schmidt, and then Melton, and then interventional radiology. And he was just coming on at the time. So it was an interesting model. I'm like, wow, I saw how just from a skill set perspective, they had very complementary skill sets and how that really, really worked well. And so that was another piece of the puzzle, I guess, in my thinking, these little things that kind of open up our minds to what's possible, not only possible, what's maybe ideal. Yeah. So that happened early on, and was kind of just another seed, I think, sitting there waiting to sprout.
Kind of planted that seed. On the flip side, did you consult vascular surgery colleagues and get sort of negative feedback, or why would you do that sort of answer?
I guess we can start to talk about that. I think within both fields, there's a cats and dogs type of thing, right? And interventional cardiology included in that, right? There's I think every field, vascular, IR, and IC, we've all got our pros and cons, and we all have our classic thinking in each one, right? I mean, vascular surgeons can, there's a huge cohort, I call it, of curmudgeonry. It's my term, and I'll put that on myself for using that term. They're awesome colleagues that mean really well, but they're thinking 20 years in the past, and that's a real thing. I think as younger generations come up, that's one thing, but also what's really sad to me is to see young vascular surgeons getting infected with that type of thinking, and it's still going on. And so that's why I think, things like this podcast are really important. So yeah, when when Neal and I were talking about this, and then things started, we came together and things started happening, I believe in being consistent with myself and everything in all my relationships. So yeah, I talked to people about it, and people on this, a lot of people were supportive and said, man, that's fantastic. And we're authentic in that. Some people are like, oh, no, that sounds great. And you could tell it sounded great, but it was a social grade, and that happened to be a couple of those classic guys. But, that's
right.
This is what's required, to really shift things meaningfully. And now where we're at right now, there's so much strength and momentum to what we're doing. We're getting excited about becoming more vocal about the model and the benefits that come from it, which we'll get into a little bit more. But yeah, I think it's a big thing. I'm sure Neal, he can talk too about his side of the fence.
Yeah, I mean, there's that prejudice, that comes from training or even earlier when you go out into the field, and you start to. It's hard to shake that off, I think, and a perfect example of that is when me and Chad joined up. I started here, we take call, and at that point we're so busy, we didn't really set like a proper call. It was just like we were both on call all the time for our respective specialties, but there's a lot of crossover, whether it be PE and then there was a GI bleed, and Chad's like, oh yeah, taking care of GI bleeds, and you're like, whoa, hold on, the vascular surgeon take care of GI bleed. But I mean, that is, the endovascular prowess that, he has, you have to kind of, that prejudice has to go away very quickly. And I think that's the problem, is that there's just not enough cross specialty exposure. And so you start practice into thinking that you're the only one who can do this. IR is so special, and we are special. We're an incredible field. We are pushing the limits with technology and with everything else we're doing as far as oncology goes, and a lot of embolization stuff. But at the end of the day, the basis of what we do is endo and vascular. And we have to understand that there's other people out there who are extremely talented, whether it be IC or vascular. And just another anecdote, before I moved here, I had a really great case in Chicago where there was a failed, I think it was a popliteal artery occlusion, and the patient went to, a big university and they couldn't recant it. There was actually a piece of wire still in the pop. In the subintimal space that they broke off. And so the guy, was going to lose his leg otherwise. So, I was talking to Chad a couple of days before that case, and he had mentioned to me that he uses a stiff glide for a lot of his recants and procedures. And where I trained in IR, it was like, unless you're doing the sharp recant venous or something, you're just not using the stiff glide in the arterial system. And so I'm in that case, and I tell my tech, we tried every wire we had. I was dedicated to getting through this occlusion. I said, give me an 035 stiff glide. And they're like, what are you talking about? Like, you haven't called for that wire in years. And I got through the lesion, and it was a successful case. And so, it really is one of those things where as soon as I got here, I said, I'm going to learn as much as I can from him as well. And luckily, he's willing to teach as much as he can as well. And there's just all egos were aside. And so the key point is when, if there's any people here who are in training or going to be graduating or early in their careers, is leave your ego at the door. If you're putting patients first, everyone around you becomes someone you can learn from to help that patient. And the whole like different specialty thing in turf war, yeah, there's a lot of economics involved. There's a lot of regional battles involved, but there's also a lot of history to that too. I mean, you go to places where cardiology's been doing peripheral vascular disease for the last 20 years, and that's just how it is. So I understand there's those kind of regional, cultural, historical kind of deep-rooted systems in place, but I think just going in without an ego and being collaborative and learning from everyone is pretty much the way to go. And this was a perfect example of that. I've become, so much better as a physician for having chat around to help me with a lot of stuff. So all in all, though, I didn't get any pushback from any IRs that I talked to about this. I mean, even at VIR in Chicago, we considered hiring a vascular surgeon. So, I mean, the thought is out there. I just think people are worried or they're scared of the complexities and they're worried about failure and the optics of it all. But hopefully this episode will encourage people to re-look into this and understand that this is pretty much the way to go. I think power in numbers and, there's really nothing we can't tackle with the two specialties together.
Yeah. I mean, I've talked to a number of different people about this and I was talking to Jim Melton and Blake Parsons at OEIS. I love these multi-specialty conferences because, for these very reasons you were just talking about, Neal, is just the collaborative approach to it, whether it be AMP or ISET or, I don't do any PAD anymore, but, even OEIS, just, being able to hang out with cardiologists and vascular surgeons and realize we have all this common ground is really nice. But I was talking to Jim about, this whole like fear of like something being stolen, right? When a vascular surgeon and a whether it be IR or cardiologist, when they join up, that somebody's going to teach somebody else a procedure. Let's say it's Euphies, right? And that vascular surgeon's going to run off and steal all those cases. It just, to me, it sounds crazy, but it's like I hear people saying these things out there. And so have you guys ever heard or seen anything like this happen, or was this ever like a fear for either of you? Let's start with you, Chad.
Yeah, I think, for vascular guys, like peripheral vascular is like that's our baby, right? And so we don't want anybody touching peripheral. We can do the whole thing, right? We can do surgery, we can do endarts, we can do endovascular. And so that's a big thing. I think collaborating with other specialists, especially interventionalists, ICs and IRs, about really thinking about all of our tips and tricks and really going deep into that space. I think there's a very much a protectionist thinking there, and that goes back to old turf battles. I think the real thing here that I would say is, ego is the enemy in your life, but also particularly in professional practice. I think in our field, the enemy isn't our other specialty colleagues. It's the disease process. And frankly, I think it's a large health system and I call it the tyranny of hospital employment. We can talk about that a little bit too, but as physicians, I think we've surrendered a lot of our power and we oftentimes divide against ourselves. And so staying in our lanes of IC, IR, and vascular is just very unhealthy and very unproductive for serving our communities, for serving our patients, and frankly, for serving our profession. And so the better ways that we can align is really critical. And so I think, the crux of this is it's the turf battles and the business wars, right? We all want to have our areas, and just call it the grill in the corners. We all want to, maintain our practice and it comes down to economics. And I think that's where when you can find a model where we're all on the same team and we all benefit, then you can say, oh yeah, what's right for our patients, our community is right for us economically as well, is right for us in our skill set, in our skill level. And that's what we have in our practice. So when it comes back to teaching other types of procedures, like I want Neal to be a stinking vascular ninja that outshines me. And he wants me to be competent in some of those advanced embo skills and whatnot, for that situation, to understand it when a patient calls in after hours, and I happen to get the phone call, or when I'm in a situation when I need to, perform when he's out of town. We had a situation like that right after he came to town. I promptly went on a long weekend vacation with my family to San Diego. I think I was talking at a meeting about, I think it might have been the SVS out there. And so I'm on the deck of the USS Midway touring that with my family. And Neal calls and says, "Hey, I've got a stab wound. A gal from a meat processing plant put a knife right through her SFA." And, she wasn't bleeding out, kind of like a tamponade. And he's like, yeah, it's occluded. I said, can you get a wire across and throw a vibe on in there? And he called quick and I answered and we chatted about it, powwowed about the case. And yeah, he called back a few minutes later. I said, yeah, got it. Was able to wire it. And hopefully he used a stiff ankle glide. But that's sorry. But at any rate, got across it, had a successful outcome. And then let the guy recover. We came back and I ended up, revising it with an open procedure. She was a young gal, I think in her early 30s. So it was an awesome, successful collaboration. But I think that's the big thing is we need to start aligning as physicians and make physicians our common denominator. So for me, when I hear of like other specialties, as vascular surgeons, we say dabbling, we say all these dabblers out there. There's the drive-by renal stenting by cardiologists. There's the, dabblers and they just want to do procedures. So that's the thinking, I think, along a lot of vascular surgeons. But I say, if you have a physician who's really dedicating themselves to that disease process, meaning they're doing the heavy lifting, they're doing the clinic, they're seeing the consults, they're seeing that patient follow-up, they're really committing themselves to the entire disease process. And they really give a hoot. They really are digging in about this and really committing themselves to this disease process completely, not just the procedures and trying to ring the till, so to speak, but they're really dedicating themselves and their practices to it. Okay, welcome to the community. And I think that's, you'd mentioned the OAIS. I was just out there at the recent meeting in Vegas, and it's a great example. I found myself on stage doing a session with Craig Walker, who's an interventional cardiologist from the South. A lot of people know him, and Brett Weichman, the current president. We were talking, about economics of outpatient care and whatnot. And there we are, 3 specialties, all collaborating, all giving our best knowledge. And so that's what it should be. I just remember being up there and just looking around saying, man, this is fantastic. And that's where we're at in 2022. And that's what we need to continue to put our efforts and our energy into, because I think that's how we overcome, a lot of things, and, from economic challenges to just, the shifting sands of healthcare. So.
Agreed. Neal, I wanted you to kind of touch on that, coming from a highly academic center, a metropolitan area like Chicago with a lot of competition. Have you heard any of that sentiment like coming out of training and stuff?
Yeah, I think people are so-called bruised in interventional radiology just from the past. I mean, in the 90s, cross-sectional imaging was drawing so much revenue. How many IRs at that time were getting out of their chair to go see 25 patients in clinic, which is my average weekly clinic load, 0. I mean, there was just no reason to do that. And we lost so much ground to cardiology, when it came to endovascular stuff and being true clinicians. So we're recovering from that we're not technicians, we're clinicians. And I echo exactly what Chad said, is that, he's supportive that if I'm going to do PVD alongside him, that, I'm also involved with wound care. I'm also involved with, managing that patient's anticoagulations. I'm involved with honing in my clinical acumen to become a provider for peripheral vascular disease from top to bottom. And now everyone's saying, well, what if, Chad wants to do fibroids? Well, if Chad is going to see the patient in clinic and know the ins and outs of fibroid disease and collaborating with OBGYN and know the medical treatments and the options and all the data on myomectomy, I mean, I don't need to teach him that. He's hyper capable of doing that and learning that and doing those procedures. Just how I can go ahead and do, biliary endoscopy and stones. Any IR out there can go ahead and start doing renal stones if they want, right? So we could all learn this stuff and do it, but then you better own the whole process. You have to, and that's why I don't think this is as big as a fear as people is making it out to be. Because you can't just go in and embolize a prostate and not see the patient before and see him weeks after. You can't. I'm sure there's going to be somebody out there who does do that, but that's going to be a very, very small number and they're not going to be successful. So in all, I'm not really fearful of it. I think people kind of talk about it because it's a polarizing topic. It's kind of like, a little bit of fear mongering that's going to happen. And I think that IR had a bad past with losing respect and losing, which we've gained back, I think, a lot of that respect in the community, in the medical community, coming out here, there wasn't a week that went by for the first year where, I wasn't the hero of the day, and it was so rewarding just because, this area didn't have access to good IR. So, we have a lot to celebrate, I think, as a specialty. And I think that we should just quiet down all the talk about losing that edge and just collaborating and moving forward together. That's the main concept.
Yeah. I mean, along those lines, Neal, you look at what like Sonny Bagle's doing with PAE, the prostate centers, teaming up with urologists. It's a similar concept, right? Just focusing on the disease process, focusing on patient care, backing that up with, knowing the data, because when you're having these conversations with colleagues, if you show mastery in the disease process, then people are going to want to collaborate with you, or at least they should, right? And so, Chad, you mentioned you were at OEIS, another plug for, I'm sure Brett's going to appreciate all these plugs, another plug for OEIS. But did you talk to anybody else when you were there about your practice with Neal? And did you meet anybody else who is maybe thinking about doing something similar or was intrigued by your practice style?
Yeah, I had a lot of side conversations with, a variety of guys that came up that were doing this. And I saw a number of guys that just happened to talk to were more, onesies and twosies trying to step out and just move from a hospital employed model to the outpatient model. That's probably the biggest type of conversation that I had, as opposed to really focusing and partnering across specialty. But I think the guys that I talked to, there was a couple of IRs, a couple of VSs, and a couple of ICs. So, I'm like, all the ingredients are there. I think the big thing is just it's market to market and seeing what, how can you align, what alignment makes sense in the local markets. And I think that comes back to not having an ego, having equal respect, because in your mind, you might even be thinking, well, yeah, I'll partner with somebody, but I think, I should make more, I should have this. No, how can you really partner in a way that makes sense and put everybody on the equal page? That's called respect, and that starts with that checking the ego at the door, like Neal said. I think really the thing that sets us apart, if guys are thinking about this, regardless of their specialty, is what Neal alluded to too, is clinical excellence. Like, I think our advantage is we are, I'll say it unabashedly, we're really good at what we do. And we're really good at what we do because we really care and we really want to, put that patient first and have that outcome. And when we're driven for that, and we're driven for, we don't, nothing dropping off the table when it comes to our patients and our care. So yeah, if I'm going to do uterine fibroid treatments, well, I better know it inside and out. And if I'm not where I need to be clinically or something, well, I better get there, and same thing. It's just that drive for excellence, for the right reasons. It's not so we can be successful economically or dominate, our region, or any of these types of things. It's so that we can really truly elevate care and really be good at what we do for the benefit of the patient. I think if that's your Northern Star, I think you can come together and you can check your ego enough, regardless of your market and what's going on. You can just stop and you can say, well, that wouldn't work in my market to have a combined practice because of this reason or that reason, or this entrenched group, or these guys have always, quote unquote, done this type of care. Pump the brakes and just say, how can this work? If I were to sit there and imagine a situation that would excite me and would probably excite, the other side, or what would that look like? And just get your mind working in that way for a while, because I bet there's going to be a way where physicians can come together to benefit care in the community. And when you start thinking along those lines, I think that's when solutions start to come, as far as how you can align motivations, align on the business front, and really start to experience the type of synergies that Neal and I have.
Yeah, I wonder, one of the other sort of, I guess, hindrances or the resistance to, people going out on their own, leaving their DR group, is hospital privileges, right? Did you guys have any challenges with that, with Chad, with like trying to get Neal? Was there a local radiology group that was like, no, we're not going to let you get in? Did you guys have any issues with that?
That's one thing that I was able to broker before Neal came, is we have two hospitals, two medium-sized hospitals in town, and with different that are connected to different systems. And so immediately we kind of became the group at one and got privileges at the other, because there was no dominant large reading group. In fact, there was the reading contract was changing at one, and that's where I kind of stepped in and was able to broker a deal, so to speak, where I knew a reading group that would be collaborative and wouldn't try and block out IR privileges. So that's where I kind of stepped up and used my position, if you will, to kind of broker that. But yeah, that could be a problem. We see that in other markets like Omaha. There's large reading groups that pretty much block anybody from getting privileges, and that can be a problem in certain markets. Which that's an interesting thing. The history of diagnostic radiology groups combined with IR groups, and that's something I didn't have a ton of awareness before talking with Neal about it. And seeing kind of what the history on that is and how that can be a big block to IRs, I think, practicing more fully.
Yeah, we're lucky that we didn't have that issue, but I read SIR Connect every morning. So, you see that just over and over and over again. And DR and IR have to split, it's a different specialty. We all know that at this point. But the more IRs out there who do team up with VS, the privileges will slowly change over time. I think hospitals will realize, I cover vascular call, for example. So, what does that have to do with IR as a whole? And so the hospital has to start seeing this from that perspective. And I'm sure there's some legality to it too, eventually, that we are a different specialty. So we can't be held to the same kind of chains of DR that we have been for so many years. So hopefully that changes soon.
Yeah. I honestly, seeing what you guys are doing and what, Jim and Blake and a few others, like I mentioned Christian Amano, who's in Columbus, who I know is looking at hiring an IR, Franklin Yao down here in Dallas, also looking at these options because, he runs an OBL and he's out there on his own and he really sees the complementary opportunities. And so I do think that this is the future of the endovascular specialties, just because these IR DR groups just get bigger, right? And it's predominantly, it's like 90% DRs in the group. And so you have very little say as an IR. And so we just end up being unhappy and bouncing around jobs. And some end up in academics, so they can do 100% IR. Some end up in less than ideal OBL settings, that are less than that. So they can be 100% IR. But really, having your own practice, the autonomy that comes with it, the potential for learning, which you guys have already talked about, is huge as well in private practice. And so I just feel like this is the future of endovascular. But kind of as we start wrapping up, anything you guys have to add to that in terms of the outlook on more collaborative practice? Neal, I'll start with you.
Sure. So one thing to put out there, there's no doubt that the stars were perfectly aligned for our situation. And I think that every different market and group and part of the country is going to have different challenges with accomplishing what we have. But a few of those things that worked for us is, number one, for anyone out there who's also listening and thinking about this as well, just don't become a cog on the wheel. Become the wheel. Our value as interventional radiologists have to go far beyond, being available for a Thor or a para. Establishing yourself in the hospital, which, as much as we do have an office-based lab and we're very efficient and productive and provide world-class care there, it's as important to me to also be providing exceptional care of the hospital. Built the Y90 program. The first month I was here, the amount of paracenteses I was doing with patients who hadn't been optimized on their diuretics, been worked up, haven't had their portal gradient calculated, was astonishing. And so we did 5 tips in the first 3 or 4 months, and talking to the staff, they're like, oh, we haven't seen one of these in a decade or ever. So the support I had from Chad to make sure that interventional radiology was being properly deployed in the hospital, starting a Y90 program, going to tumor board, all that was there. It was the support was there to do that. So basically, though, our stars were aligned in the sense that we had a need and I had a supportive partner. And I think the specialties aside, that's really, really important. Moving forward, our practice name is Vascular and Interventional Specialist of Siouxland. And I think that term embodies what it should be moving forward in the future is minimally invasive procedures with better outcomes, lower cost, technology driven, and that's it. It doesn't matter what your specialty is. If you're providing those things and you're doing it perfectly, or you're doing it as best as you can, and you're putting your blood, sweat, and tears into it, you're going to have good outcomes. You're going to have great patient results. You're going to be changing communities and populations. I think it's worth noting that our amputation rate in the Siouxland community, which is 180,000 people with a 80-mile radius, is near zero. I think, Chad, you can attest to that. And
yeah, we've made a huge impact in our community, I think, which has been really satisfying. I think, the future, there's a huge opportunity, I think, for physicians to move from an hospital employed model back to a private practice model where we have the decision making in our hands as far as patient care and as far as how our lives look. I think that dovetails very, very nicely with having a combined vascular, interventional radiology, and or interventional cardiology practice. And I think there's a huge opportunity in secondary markets. We talk about the big cities and things can be really entrenched with tons of history there. I'll tell you, a lot of people, even more so post-COVID, are living in what we call secondary markets. It's markets, say, of a main town of anywhere from 25 to 100,000, maybe 150,000 people. And there's a huge need out there. And we look at these human lives that are out here, and oftentimes the demographics in those areas overall really support a need for our specialties. And so, I have a vision of, and we've talked about this a lot internally and are making good progress about, pairing specialists of any specialty, IC, IR, or vascular, having them come in and maybe do a master's course with us for a short period of time, 1 to 3 months, really get down what we do and see it and scrub with us even. And then being able to launch them in a secondary market, and being able to pair a proper specialist with a proper market, but then also that market, just like our market, has benefited tremendously by bringing in, world-class IR talent with Dr. Khurana and having my curmudgeonly hands working away, but putting us, using this model and maybe a certain town may have a huge need for IC and vascular, or a huge need for IR and IC, and we can kind of make those matches, maybe onesies, maybe twosies, maybe threesies in these communities. And I think if we really want to shift things, nationally in a meaningful fashion, I think that's a great way to do it. So we're looking at doing something like that and using our practice as, a base to do that with, call it a master's course in outpatient care, but with that collaborative ethos. I think that's a huge way to serve our country, serve our patients, in that. So that's exciting to me because I think that's a very practical way to do that. And, our practice is vascular interventional specialists. And I think that's really, it's what we are and it's what we represent. It's how we practice. And we're going to be launching our new site, vascularcare.com here in August, where it's going to be we want it to be a huge combined site that has, all things vascular, all things IR on it as a resource for our patients and for us. But it's, we're excited about taking more steps into this combined practice, collaborative practice model, and then finding a practical way to really encourage that and multiply that.
Chad, that's a great idea. I love that sort of micro training, 1 to 3 months. Would those people take call with you guys? Would that be like almost like it's like a master's course, like kind of mini fellowship, right?
Right. I mean, you almost don't want to use the word fellowship because we'd be looking for guys that would been out for, a couple of years probably to whenever. So they're going to be much more probably experienced guys, so I call it more of a master's course, but you're right. Yeah. Bring them in and hey guys, come and see what we do. And it's a short period of time. I mean, you could probably even offer a stipend if guys needed that and really grease the skids to get them here and really get them connected, really get their hands, I was going to say dirty, but it's more like bloody in our field.
I'll tell you what, because there's a lot of people, and you're right, Chad. I think the pendulum swinging back, it went to employee because people were just, wanted to just get a job. And then now people want that autonomy back, and it's swinging to where you hear about more and more people going out, opening up their own outpatient practice, whether it be OBL, ASC, whatnot, but at least opening up their own practice. And regardless of the money, it's all about, I think, just autonomy and better patient care, right?
Absolutely.
Having the ability to make those decisions for your patients, having the ability to decide what devices you're going to use for your patients.
Absolutely.
I mean, it drives me crazy being in the hospital and they're just like, nope, this is what we got. It's the cheapest device on the market. And you're like, this is garbage. This is not good. This is bad patient care, and that's where they're headed.
100%. It's crazy. Like we go to the hospital and to jump in on that. I mean, we even have a lot of people that say, well, we can use what we use, but there's so many times that if you want the most current technology in any product, I mean, from superior stents to a certain atherectomy device to drug-coated balloons, we use those all in our outpatient center, and we use what we know works, and we practice. I said we practice to our professional conscience, and there's no other place where all things align. If you want amazing patient outcomes, an improved patient experience, patient reviews and their experience off the chart. You want to have, professional practice to your professional conscience. Oh yeah, and your staff are super happy and have stepped out of their burnout situations that they're working in. At the Physician Matters, our lives are amazing as far as that burnout aspect and care. It's like all things align. And it's a phenomenal model, that outpatient model. So that's why that's a big reason why we're so excited about it too.
Yeah, we could probably do a whole episode on that, which I know, Aaron, you've definitely covered OBLs and the freedom and the autonomy and the better patient care. We could talk about that for hours, but when I first came here, that was the biggest thing for me was, oh my gosh, you guys have a penumbra sitting in the corner. Well, yeah, if you're doing angiograms all day, you better have one in case something goes wrong, and there should be no fear of opening that up or an outback or whatever you need to get the case done and make sure it's successful. It was really a relief to be in that situation. So,
well, there's so many micro topics within the OBL topic, right? I mean, the staffing, there's so many decisions that you have to make as a business owner. I mean, just the whole business aspect of it is a zillion micro topics, So we will be covering this, for as long as BackTable exists, most likely. Chad, I didn't mean to cut you off there.
No, I think you hit the nail on the head. That's why, like a master's course makes the most sense. Like, you have to have the proper clinical decision-making algorithms, like we've talked about here, that clinic side. You have to have the proper procedural decision-making algorithms. How do you get cases done effectively, efficiently, really well? Not just crossing lesions, but crossing it well and crossing it time efficiently, and then really debulking that plaque. Just the procedural decision-making algorithms are great. When to deploy to pedal access, et cetera, but then you also have to have the technical skill to back that up, right? You can't fake any one of these pieces, and you got to have the complete package, but then also you need the clinic operations ability and understanding. You need the procedure center operations and management understanding. You need revenue cycle understanding. How does the revenue cycle work specific to our outpatient model? And then I feel you need mindset as well. Like, what are the weeds that a lot of guys have in their minds that are going to, cut their success off at the knees? Let's talk about those things. So I'd envision having, what we're putting together is even a didactic courses on each four of those topics that go along with our clinical, scrubbing in and doing the clinical work too. I mean, it's really exciting, I think, to really give guys like, what's the secret sauce on the business, so to speak.
Well, and a lot of guys who are, thinking about doing this, they're in the planning stage. They have time on their hands to go do a math like 1 to 3 months, right? Whether they're breaking ground, their OBL is being built. They might do some locums on the side to keep their skills up, but this actually sounds better because then you could it's peace of mind. I'm just going to go learn it from you guys, whether it be wherever my weak points are, right? Whether it be PAD, Y90, whatever, I can focus, PAE, I can zero in on that when I'm with you guys for those 3 months and really get those reps in, right?
Absolutely.
So I love that idea.
Yeah, come get 15 angios a week, 15 and real stinking complete SFA occlusions, iliac occlusions with SFA, get, 10 pedal accesses in a week, and let's do this. Let's get you there. Let's get you there fast,
Get familiar with those complications and how to deal with them. And I mean, cause I was in the OBL setting briefly and the people I had teamed up with were oblivious to all of that stuff. And that's why we failed. I mean, partly my, ignorance, but theirs as well on the business side. And, to have a resource like that would be amazing, where I would just be like, I'm going to go do this for 3 months, guys, so that I know everything I know so that we have a better chance of success. Because you guys know there's a lot that goes into not just elbow grease, but just the knowledge that goes into being successful. But guys, we're at the hour. Anything else any final words before we finish up? Neal, Chad?
Just a big thanks to you, Aaron. I mean, just to focus on these topics that are somewhat non-clinical, but they're absolutely crucial to patient care and for our success as a specialty. I know you guys aren't an interventional radiology show, but I know you do put in a lot of effort to keep these going. So thanks a lot. And Again, I'm going to say it out here. Thanks to Chad. And this has been an amazing opportunity for the last couple of years. And I think we're going to be here for a long, long time, making big things happen.
Yeah, I'd echo what Neal says too. Just thanks for having us, Aaron. Really appreciate it. You know, we Neal and I tend to be doers, and we've been in our foxholes, as I say. So it's good to almost feel a responsibility to get out there and start giving back again and do that in a greater fashion. I mean, you've been doing it with your show and your content and bringing light on a lot of these issues and bringing guys together. So really grateful to having us on. Again, super grateful for Neal and for what we're able to do here in our local our local region. So just really appreciate it.
Yeah, and Neal, it's funny because you mentioned the name of the practice was Vascular and Interventional Specialist, and because we started out as a IR show, and we're still heavily weighted towards IR, but I'm trying to get more vascular surgeons and cardiologists on, and because of that, we changed our name from BackTable to now it's BackTable Vascular and Interventional, or the VI show, and because I want it to be more of a collaborative, covering all things vascular, all things interventional, and learn from each other. And so I think that's it just kind of mirrored what we had in mind when we changed our branding a little bit. So appreciate you guys, and hopefully this isn't the last time we have you on. Hopefully we'll be talking about these micro training, these master classes next time.
Definitely.
Awesome.
Thanks, Aaron.
All right, thanks guys. Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritts, and co-hosts
Chris Beck,
Sabine Dond,
Michael Barraza,
and Ali Behetti.
Our audio team lead is Kieran Gannon, with support from
Caleb Hodson,
Josh McWhirter,
and Ness Smith-Savadoff. Design and digital marketing led by Brian Schmitz.
Article and transcript support by Taylor Robinson.
And Delaney Aguilar.
Social media and PR by Ann Dang.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening, and see you next week.